history of dysmenorrhea, dyspareunia. That might indicate they have endometriosis. They might have lower abdominal pain or that pelvic pain or even back pain, especially patients that are postmenopausal with ovarian cancer, lower abdominal bloating, abdominal discomfort. But most of these patients aren't in a lot of pain. They're not in a severe amount of pain. They're just like, something just feels off. Something just feels off. Okay? Of course, they can have acute onset of pain. It could be extremely severe if you have a rupture of an ovarian cyst or if you have ovarian torsion. That fever with an abscess, pressure or bloating is going to be more common with ovarian cancer. If they have abdominal bleeding, evidence of virilization, that might be from something like PCOS or even something like a Sertoli Liebig cell tumor. That's going to cause excessive virilization, where they have a lot of facial hair or maybe even hair on their chest, excessive abdomen, that kind of stuff. So you want to make sure we get a good past medical history on these patients when they come in, a good gynecologic history to include an STI history. Do the review systems. Have you had any unintentional weight loss, any abnormal night sweats, or intermittent fevers? And what about any STIs, and when was your last STI? What was it treated with? Because we always make the assumption that the person before us was smart and they treated these patients appropriately. You will find that that is not the case sometimes. You'll find that someone, who's 75 is still practicing medicine that they learned in the 1940s, right? Meaning, let's say this. Someone came in and they had gonorrhea. What is the dose for your ceftriaxone? 500. Well, guess what? There's still people giving 250, right? Because that's how they trained and they've not done any additional training since. So you want to make sure these patients get treated appropriately. Get your family history. You're going to do your OPP-QRST. Make sure we get that pregnancy test so that we are sure that these patients are not pregnant. You've got to look at the vital signs. Sometimes these vital signs are a direct reflection of the amount of pain this patient's in. If they're tachycardic, that might be due to the pain. If they are tachycardic and hypotensive, that's not due to pain, folks. That's due to, we've got some blood loss somewhere, maybe from, most likely from a hemorrhagic cyst that is ruptured, and they're continuing to bleed. If they're walking down to the clinic or the hallway, texting on their phone, walking normally, we can say that they don't appear to be in significant pain. However, if they're hunched over and walking kind of lightly, that's your indication that, yes, in fact, this guy are in a significant amount of pain. Even if they come to you, because remember, some patients have a really high pain tolerance, and you ask them, what is your pain level? And they say, I don't know, maybe like a 5. And like, yeah, but you're like all hunched over, like, I don't know, like, that I don't know. They'll tell you they have a pretty high pain tolerance. Your exam should include a pelvic exam, a speculum exam, a manual exam, lower abdominal exam, rectal, vaginal exam as well. Check the lymph nodes. Check the lymph nodes. Sometimes that's your first indication that there's something bad going on. And listen to the lungs. Sometimes it's been a while, but these patients have these symptoms. By the time they come in, they already have metastasis. Okay, any indication of that, then you're going to have to expand your differential and expand your workup as well. The number one radiology study of choice for evaluating anybody that has pelvic pain or adnexal mass is going to be a transvaginal ultrasound. It tells us about the size, if this is cystic or solid, again, if we have septations, is there free fluid in the pelvis? Sometimes there's free fluid in the pelvis, and the radiologist will comment if it appears physiologic, meaning based on the time period in their menstrual cycle, this would be a normal event that can occur, normal process. So you want to make sure when you order these transvaginal ultrasounds that you put in when their last menstrual period is, because it helps the radiologist as well. If for some reason we can't do a transvaginal ultrasound, the transabdominal ultrasound would be okay. So a patient can't tolerate the transvaginal, the mass is too large, or they try to do a transvaginal that they evaluate and they see a large mass, they may have to do a transabdominal in addition to the transvaginal to get the entire mass in the ultrasound. CT, MRI, PET scan, not in the initial evaluation of adnexal mass, not in the initial evaluation. We're using these more to evaluate the metastasis. We're using these more to monitor the patient's progress when they're being treated for different things. But we're not using them to really assist us in our initial evaluation. Again, yes, maybe you did a CT abdomen pelvis for some other reason, identified this adnexal mass. We're going to go back up and order the ultrasound. We're going to think of that ultrasound as our tool of choice for evaluating the adnexal mass. CA-125. I think you guys have probably learned about the CA-125. It's the most widely studied biochemical method for screening for ovarian cancer. It's been out there for quite some time. It is elevated in about 50% of women with early stage ovarian cancer, 80% of women with late stage ovarian cancer. That means up to 50% of women, we get this CA-125 and it's negative, and we say, well, it can't be cancer. But they have cancer. 80% have advanced stage cancer. That means it's only 80% accurate. 20% were missing. That's a lot of people that were missing. So we can't rely only on our CA-125. It's not very specific either. It's not sensitive and it's also not specific, which means that there are things that can cause it to be falsely elevated. If someone is pregnant and you do a CA-125 on them and you didn't do a pregnancy test, pregnancy itself can elevate the CA-125. Ovarian cysts can elevate the CA-125. Benign ovarian cysts, endometriosis, fibroids, all of those can falsely elevate the CA-125. So we want to make sure that we do our history physical exam. CA-125 may be part of it, but the only time that I've ever ordered a CA-125 was when the consultant asked me to order a CA-125. Meaning we were pretty certain the patient had cancer and they wanted a baseline marker for the CA-125 because they'll help that as they'll follow that as they're monitoring the patient along in their treatment. So usually it's more efficacious. We use it to monitor treatment progress as opposed to help us with the diagnosis, specifically if someone has cancer or if they don't. Other labs you want to get ACG, CBC, especially if they're hypotensive tachycardia. There's nothing wrong with getting basic metabolic panel. Other things we think about is LDH and alpha-fetoprotein. Those are really important, especially if we think this is a germ cell tumor. And sometimes we have no idea, so there's nothing wrong with just adding those labs on for your basic labs, and that kind of helps if they're elevated. In the setting of an adnexal mass, that's your indication this is probably a germ cell tumor. Treatment is going to depend on what we identify as the cause of the adnexal mass. It also depends on the patient's age. It depends on their reproductive status. Do they still want to have kids or no? Most of the time, treatment is going to involve some sort of surgical intervention. Okay, if you have really small follicular cysts, corpus luteum cysts, those are going to typically go away on their own in a couple of months, right? But if you have these larger cysts, oftentimes we think about surgery, and we can do a cystectomy where you remove the cyst itself. You can do a salpingo-oophorectomy, and that is removing the fallopian tube and the ovary. Or if there's evidence of cancer, they usually recommend a total abdominal hysterectomy or a total vaginal hysterectomy with bilateral salpingo-oophorectomy. So we're going to remove the uterus, both ovaries, and both fallopian tubes. All right, so we've got this case here. Haddleton. In the back, isn't he? There you are. Oh, you just moved back there. You were looking at that. Okay. All right, sir. We're going to go through this. We got a 23-year-old, G1, P1, 1 pregnancy, 1 delivery. Comes with cramping, lower abdominal pain, right pelvic area, last 3 days. Menstrual cycle was 2 weeks ago. Normal. Condoms for contraceptives. Pregnancy test is negative. There's a 3 to 4 centimeter mass that you find on your examination in the right adnexal. The remainder of the examination is otherwise normal. What do we think in our differential diagnosis? Well, we can use this cheetah's mnemonic, right, to help us in our differential diagnosis. So think about this. She's 23, recently had a menstrual cycle. We've got a 3 to 4 centimeter tender mass on the right adnexa. Okay. So she's not seeing severe pain. So what do you think? If you were to choose, go down this list, give me 3 of your top things that you choose that this might be. Abscess. Simple cyst. Endometrioma. Okay. So those are things that are possible, right? So we're going to ask her about the disease. Does she have any of those signs and symptoms? We're going to look at the vital signs. If you have a fever, what else might we want to ask her to help us identify, rule in or rule out this abscess? Any recent STI history, right? And then, what do you think the next step is going to be? What do you want to do? We're going to do an ultrasound. We're definitely going to do a transvaginal ultrasound. All right. When we do this ultrasound, and man, you got some good hands. You happen to find out, ultrasound says, yep, you are exactly right. 3 centimeter cyst, right? So 3 centimeter cyst noted on the right ovary, looks to be a functional cyst or a simple cyst. Okay, no free fluid in the pelvis and no ascites. If you see something that says ascites is present, that's bad. That is bad. Something bad is going on, right? Something you got to figure out what it is, but something's causing it, and it's usually not a good outcome. All right. So in the end, this person probably has that functional cyst, just like you mentioned, that simple cyst. This is the most common cause of ovarian cysts that we're going to see. We talked about follicular type cysts and corpus luteum and how they differ a little bit in how they develop, but really kind of the same presentation. The follicular cysts, we just have that egg that it didn't rupture, we don't have a release of the egg, so we get fluid that goes in there. Corpus luteum doesn't completely degenerate, so we get fluid that goes in there, and they continue to grow. And then that hemorrhagic is going to be the more that painful, where you have blood that develops in that cystic area, and we hope that it doesn't rupture. Many that do rupture, and these patients are okay, you just don't know when they rupture if they're going to continue to bleed or not. Many of these patients will come in more with that dull sensation. And then just have this ache in my pelvic area, my adnexal area. On exam, it's usually unilateral, because that's usually, we will release an egg from one ovary. And again, no evidence of ascites on our imaging. If it's hemorrhagic, that's going to be still unilateral, but more severe pain, more sudden onset of pain. And we're going to look for peritoneal signs in those patients. So what do we do about these patients if they're premenopausal, they're coming in, they've got this adnexal mass, we do the ultrasound comes back, and it says, yep, got this functional cyst, it's less than 5 centimeters, we don't really need to do much about it. And the reason is because we know that this specifically came from a cyst that developed because the egg did not rupture, or the egg was not released, right? And so what will happen, the body will reabsorb that fluid over the next couple of months, and there's nothing specific to do. If it is 5 to 7 centimeters, we do recommend follow-up, and some places will say 4 to 6 weeks, some will say 6 to 8, so we do about 6 to 12 weeks, because we know if we follow it up really in a month, it is likely that that cyst will still be there. We want to follow up in a couple of months to make sure it's not getting bigger, or we have improvement, or it's completely resolved. Okay, greater than 7 centimeters, these patients need to be referred to GYN. You guys have any idea why we say 7 centimeters needs to be referred to GYN? So if your ovary is like this, and you've got a 7 centimeter cyst on there, and now your ovary like this, you're doing this to your ovary, making that ovary very lopsided, may increase the chance of that ovarian torsion. Okay? And so it'll make the ovary lopsided, the ovary tores, and that's the problem with these larger ovarian cysts. So 7 centimeters or greater is when we refer, and sometimes GYN will order a CT of pelvis or order a pelvic MRI. That's not something you need to do. We're really sending them not because we're concerned about the cyst itself, but we're concerned about the size of the cyst and then the secondary effects that occur because of the size of the cyst. For these patients, especially these ones that have the smaller size cyst, or even the larger, you can still give them anti-inflammatories that will help with the inflammation and help with pain control. And then combined oral contraceptives. Combined oral contraceptives can help inhibit ovulation. Actually, there's many contraceptives we could give our patients, right? We do the implant, we do Depo, because they all inhibit ovulation. So you can put them on a contraceptive that inhibits ovulation. If you're inhibiting ovulation, we're not even thinking about releasing the egg. We're not even getting to that point of releasing the egg, right? And so that will reduce the chance of reoccurrence in the future. It doesn't get rid of the one we have now, but it reduces the chance of reoccurrence in the future. Again, even the 7-centimeter one, it's not that you can still give them those meds, but they also need to be referred. That's the primary thing that needs to happen for those patients. Because they can go out for a run, or they can jump, anything like that can cause an overexposure because it's already lopsided. Postmenopausal patients. Again, postmenopausal patients shouldn't have things growing. So we're a lot more serious with the size for these patients. If it's less than 1 centimeter, so we talk about 5 for pre, now it's 1 centimeter, we don't have to do anything. It's 1 to 5 centimeters, we talk about maybe adding the CA-125, definitely a follow-up in 6 to 12 weeks to make sure that this is not increasing in size. Okay, if we have an elevated CA-125 greater than 30 international units, all these patients are high risk, GYN referral. And honestly, like I told you guys before, these patients postmenopausal, I may order the CA-125, it's the same time I'm putting in a referral. I'm going to have them see the consultants because they're the patients that are going to be able to help us monitor these patients. Okay, greater than 5 centimeters, they've got to be seen by GYN. And not necessarily for the same reasons. Not necessarily that's going to increase torsion, although they can have torsion, but it's just because we're much more concerned this is probably some sort of cancer because of the size. We still give them anti-inflammatories for pain control. We'll do an initial CA-125 to help us identify a baseline, and then the LDH alpha-fetoprotein, especially if we're concerned with this germ cell. Now, if they come in and you do the ultrasound says it's a hemorrhagic cyst, and they are premenopausal, less than 5 centimeters, you don't need to do anything about it. 5 to 7 centimeters, we need to do a repeat ultrasound, and if it persists, which would be very unusual, then they need a GYN referral. There's something concerning that. Their body should be able to reabsorb that. And if it's not being reabsorbed, there's something unusual, very concerning. If they're early postmenopausal, that's the first 4 years after menopause, do that CA-125, repeat ultrasound in 6 to 12 weeks, okay, and then GYN referral if it persists. Okay, late postmenopausal, those patients greater than 4 years past menopause, then they need a GYN referral. We've got cysts that are 1 centimeter, we got cysts that are 5 centimeters, and then we got cysts that are 30 centimeters. Size actually does matter when it comes to cysts. So you want to make sure that we understand when we're seeing these patients and we get these reports back that size does matter on how I'm going to manage this patient either in the primary care setting or is this a patient that needs skin care. So this is a very large ovarian cyst in a patient that came in and had symptoms for years. This was benign, it's a benign cyst, but had symptoms for years, but she hated going to the doctor. By the time she came in, she looked like she was, 9 months pregnant, really. And it was all coming from this very large, probably, I think when, I don't remember what the follow-up was, but I think it's most likely a cystic adenoma as the cause of this. We want to think about how these patients are presented. Okay, if someone comes in and they have adnexal signs and symptoms, some discomfort, we do an ultrasound, they have a 3 centimeter mass, like, okay, that sounds appropriate. But if they come in, they're writhing in pain, severe pain, okay, right lower quadrant, and we ultimately get an ultrasound that shows a 1 centimeter cyst, that doesn't make any sense. Why would they be in so much pain with a 1 centimeter cyst? Why? So we want to make sure that just because we see this cyst, does that account for the patient's presentation? Because sometimes we catch these cysts, what's what I'm thinking of?
Early?
No.
Late?
No. Sometimes these patients come in and we just happen to do the imaging And it's like, on routine imaging, we happen to catch these, so we just accidentally identify these. But then we hold it to, we say, well, that's probably the reason why you were in such severe pain. You have this 1 centimeter cyst. No, you just happen to accidentally caught that. Now you gotta really figure out what the actual cause is for the cases. We see this a lot in urinary tract infections. Patients come in, they have, signs and symptoms of a UTI, pain, burning, and then they have, they have a fever, they have flank pain, and they have 8 white cells in their urine. That doesn't make any sense. And then you put your finger on it and you say, oh, that's probably why you have a fever and you're tachycardic and you have CVA tenderness because you have 8 white cells in your urine. No, that doesn't go in correlate with that. And if you send them home and you only treat them for UTI, they're going to come back septic, because treatment for UTI is different than treatment for pylori, right? You have to use different medications. So same kind of symptoms. All right, so this girl comes back. She's coming back for a follow-up visit. Redolin. Okay, ma'am. Okay, she's coming back for a follow-up visit. She's feeling better. Pelvic exam is unremarkable. What do you think you want to provide for her or recommend to help reduce the chance of reoccurrence for her cysts?
For reoccurrence,
probably a COC, right? Yep, so NSAIDs will help with discomfort, but it's not going to help with reoccurrence. Levonorgestrel IUD does not routinely stop ovulation. Okay, so, and then GnRH agonist, and there's no role for that in this. Copper IUD also does not affect, so very good. Combined oral contraceptives would be our medication. All right, we've got another case. Cryer, yes sir. 25-year-old comes in, painful sensation, fullness in her right lower quadrant, going on for several months, regular menstrual cycles since she started menarche, no history of STIs. She's got a mobile mass in her right adnexa, HCG is negative, and you say, well, I feel like this is about 8 by 8 centimeters. What's your differential?
Cyst. A cyst.
Simple cyst?
Teratoma.
Teratoma?
Maybe cancer.
Maybe cancer. 25-year-old. Okay, maybe cancer, that could be. Okay, cystoadenoma might be on there as well for this age group. Okay, you got to order an ultrasound, and on that transvaginal ultrasound, bang, you're good. 8 centimeter right adnexal mass. On here, though, it says from the radiologist, mixed component of solid components and calcified components in there too. No ascites, left adnexa is unremarkable. Okay, so now what is your most likely diagnosis of these? Dermoid cyst. Dermoid cyst. Yeah, I think I'm with you. 8 centimeters by 8 centimeters, that's a pretty large cyst. So dermoid cyst, otherwise known as teratoma, is going to be the most common benign solid ovarian tumor that we're going to see. It is part of the germ cell family. Very slow growing. Again, this is something they've most likely had since birth. And so because it's so slow growing, most of these are not diagnosed in teenagers. We're talking about more 20s, 30s, and even on upwards of 50 to 60 years old sometimes for these teratomas. Okay? We can see these in much younger girls, but it doesn't mean we necessarily have to intervene with them. If they come in with, like I saw an 11-year-old in Uvalde with a teratoma. And they took it off because she was in a tremendous amount of pain. About 15% of the time, these can be bilateral. And they're oftentimes composed of ectoderm, endoderm, so we've got sweat glands, sebaceous glands in there, we've got hair follicles, we've got teeth, pretty gnarly looking. They can get upwards of 10 centimeters and sometimes even a little bit larger than that as well. When we take these out, this is usually what we see. We have this hair in here, we have a little bit of teeth growing. Any thought? Did you guys know what the thought is and where these come from? Twin. So one of my really good friends is from Virginia, and she had a teratoma. And so I was talking to her mom one day, and I was like, oh my God, did you know that she had a teratoma? And they said that's probably, comes from the literature says it comes from a twin. She's like, Susie, what are you talking about? She didn't have no twin. I said, no, like I'm just saying like that's what the literature says. I don't know what you're talking about. And I'm like, forget it. Never mind. So make sure that if you tell somebody that, like, you have the right audience. Otherwise, you're going to be like beating you up. Like, I'm like, never mind. And I did not show her any pictures. If I was showing her pictures, like, she'd probably be like, that is not your friend. But I did ask, like, did you bring it? Did you bring it so I can see it? She's like, no, that's weird. No, it's actually not. All right, so what do we do for these patients? Well, it really kind of depends on the size of the teratoma, but usually if it's greater than 5 centimeters, they're going to recommend removal because it does increase your risk of ovarian torsion. And she was actually, my friend that had this was actually having intermittent ovarian torsion because hers was like 9 centimeters, and she'd had multiple episodes of severe abdominal pain that lasted for an hour or two, then went away. And so this could cause that intermittent ovarian torsion. So they can remove just the teratoma. Oftentimes, because it kind of really attaches to the ovary, oftentimes it ends up in a unilateral oophorectomy. And depending on the size, sometimes they have to do an open procedure, sometimes they can just do a laparoscopy. If they're premenopausal, again, less than 5 centimeters or no symptoms, we can repeat that ultrasound routinely and make sure it's not growing, make sure there's no concerning factors, and decide if they want to take it out. If greater than 5 centimeters, we typically take it out. If they're postmenopausal, we want to refer these patients. All right, well, even though we got started late, we got to take a break. 32-year-old female coming in to the emergency department. Sudden onset of left lower quadriplegia started 2 hours ago. Sharp, comes in waves, says nausea, vomiting. On exam, it says left adnexal fullness and rebound and guarding. ACG is negative. Previous ultrasound, she had a 7 centimeter ovarian cyst. Give me your top 3 differentials. Torsion. Simple cyst. What else would you think would cause a sudden onset of this differential? Hemorrhagic, okay. So, of these, what do you think is your diagnosis? Ovarian torsion. Certainly concerning for that, right? An ultrasound was done, there was no blood flow to the left ovary. Now, when you do this ultrasound, what kind of ultrasound are you going to order, Miss Sy? Transvaginal, transabdominal, trans what? Transvaginal ultrasound. All right, patient was taken to the operating room and diagnosed of torsion. And ultimately, what we can see here, you guys can look at the picture, you can just see that, so we have this, it's just twisted. The ovary, you can't even see the color of the ovary because it's so edematous, and there's blood in there. And so they ultimately did a left salpingo oophorectomy. Salpingo oophorectomy, which is the ovary in the fallopian tube, was taken out. When we look at the how ovarian torsion happens, we have this rotation or twisting of the, could be sometimes just the ovary. So most of the time it's the ovary and the fallopian tube on the ligamentous and the vascular support structures. And it can cause a complete loss of blood supply or a partial loss of blood supply. But you don't know that exactly what's going on until you get the ultrasound. Right? You got to remember that the ovaries are not specifically affixed in the abdominal cavity. They're not free floating, but they're held within broad ligaments. If you're going to have an ovarian torsion, it's typically more common to happen on the right than it is the left, because the left has a sigmoid colon that kind of protects it, but it can happen either the right or the left. About half of the, or a quarter of the time, this can actually occur in pregnancy, which really is a big confounder because they're pregnant, they're having abdominal pain, so you know if they're, are they miscarrying, or ectopic pregnancy, so it's, yes,
Usually later in pregnancy.
it can occur at any point in pregnancy, at any point in pregnancy. So I would say, I think I've only seen one case of this ever in pregnancy, even though it can occur at time, and they were kind of early in the second trimester, but it can occur at any case because we have an increase in estrogen all throughout pregnancy.
With these symptoms and you get the HCG, you should just jump to ectopic. You have to do the imaging.
Still have to do the imaging. Yep, yeah. So when you get the HCG, and they would have a download, you're going to get the HCG, and most of the time they won't even do the imaging until the HCG is back. And we're not getting just a positive, negative HCG. We actually need an HCG quant. They want to know what is the level of the HCG, because then it'll help them correlate. Okay, is this in fact an early pregnancy? Is it an early ectopic where we don't see anything? Because sometimes that ovarian torsion is not that easy to identify on Doppler, especially if they have partial flow. They do the best they can, but it's not 100%. Man, what is that smell? Someone did, was it broccoli? I don't think it's you. Maybe it's you.
There's broccoli.
Maybe it is. Whoa,
Then you got good
someone's
nose.
eating something. I
Broccoli
love
and chicken.
broccoli. Okay, and then, when we look at this, majority of these patients had some sort of ovarian mass to begin with, probably a cyst, okay? And again, we were gonna watch those cysts, but if they're larger cysts, we know that increases their risk of ovarian torsion. And of all the things we think about for GYN, we don't really have that many GYN emergencies. Even ectopic isn't like we can treat that ectopic pregnancies actually as an outpatient with oral medication. This is something that has to be seen by GYN today. Ectopic needs to be seen by them as well, but they don't all get admitted. These patients typically get admitted and they've got a detorsion. If they have an active torsion, they have to detorsis. What you will find is the issue that you'll run into is the intermittent torsion. Because now you've got to convince OBGYN that it is in fact intermittent torsion when the patient is sitting in front of you and have no symptoms at all right now. Yes, but they did have symptoms. They had severe abdominal pain and they have a 7-centimeter ovarian mass. You would think that in your mind, like it would totally make sense, but for some reason, sometimes it doesn't make sense to them. So these patients are going to come in with that sharp low abdominal pain, sudden onset, and it typically gets worse and worse and worse over the next hour or two, and then they come in to see you because they're in so much pain. If you can have radiation down to the thigh or to the flank area as well, so sometimes this could be mistaken for kidney stones. Kidney stones, because kidney stones have flank pain that can radiate up and down as well. Most of the time they'll have some sort of adnexal tenderness, oftentimes have rebound referred tenderness, maybe a low-grade fever for these patients, but oftentimes they'll have at least an episode of nausea and vomiting. They may not have persistent, but they oftentimes will say, yeah, I felt really nauseous for a while, but that's kind of better. And then in transvaginal ultrasound, that is the study of choice for these patients, we'll see that lack of reflex, so we'll order a Doppler. You must put on there, evaluate for ovarian torsion. Otherwise, they won't necessarily do a Doppler. They're supposed to do a Doppler. They did, so, every ultrasonographer, when they do these, they're supposed to, but you want to make sure you're evaluating for ovarian torsion. Meaning, if you're seeing this patient in the clinic, they're going via ambulance to the emergency department because you've got to be able to get that ultrasound. Okay? And again, just because we have flow doesn't mean we don't have torsion. We have a partial torsion. So if we have a high index of suspicion, it's best to talk to the consultants and run it by them and have them look at the imaging themselves, have them come see the patient. Because a lot of times they'll be like, well, do I need to come see the patient? That's what I'm calling them. That's what I'm calling you. So in the ER. Now, if you're working the outpatient in primary care, they're not coming to the primary care clinic. I'm concerned enough, I'm going to order the imaging, but I would like them to see her. They're okay right now. I want them to be able to see you in your clinic in the next couple of days and be able to put down your referral in. So ectopic pregnancy, tube ovarian abscess, hemorrhagic ovarian cyst, endometrioma, those are all the differentials that we want to think about, and we can help rule them in and rule them out with physical history, and then our physical exam and our imaging. CT, MRI really don't play a significant role in the initial evaluation of this patient's complaint. So how do we treat these patients? If they can, they will try to salvage the ovary. Sometimes they can just remove the cyst that caused the torsion via cystectomy. Unfortunately, many times it results in removal of the ovary and the fallopian tube, especially if there's any evidence of necrosis at all. That will cause a pretty significant infection if they don't remove that with necrotic tissue. So they're going to ultimately remove whatever necrotic tissue that is there. If they have a complete ovarian torsion, usually they're going to remove that ovary and the fallopian tube. Again, this is a surgical emergency. This is not go home and see how you do with some combined oral contraceptives and anti-inflammatories. This is, you've got to go to the ER for that. Case 4, McMillan. Okay, you got a 32-year-old female, routine annual examination, no complaints. She does have a history of chlamydia infection a couple of years ago, but says she was successfully treated. On exam, though, you feel some adnexal fullness on the left side, about 4 centimeters or so. Otherwise, the rest of the exam is normal. So again, she's just here for her routine cervical cytology or cervical cancer screening. No other complaints, but you identify this on exam. Right? What of these do you think is going to be your top 3 differentials?
Simple cyst,
Cyst,
abscess,
abscess,
and fallopian tube cyst.
hydrosalpinx, fallopian tube something. Okay. Anything else? I mean, really, dermoid cyst could still be in there, right? Because she's asymptomatic. Cystoadenoma could still be in there. Yep, okay. So you order a transvaginal ultrasound based on not the fact that the patient had no complaints, but you identified something on physical exam. And oftentimes you guys will talk yourself out of it. Well, the patient's not having complaints. Maybe I'm making it up. I don't know. I haven't done that many of these. Maybe it's me and not her. But if you feel something or you identify something, then you do. And guess what? If you get the ultrasound's completely normal, you're like, okay, great, it's normal. That's good to see. But this ultrasound is not normal. It noticed that there was a tubular structure adjacent to the left ovary, but the left ovary itself appeared to be fine. No pelvic free fluid in the pelvis. Okay, so now what do you think is going to be your most likely diagnosis? That hydrosalpinx. So think of this, we haven't talked about. Dermoid is going to be a focal mass on the ovary, ruptured ovarian cyst. These patients, it wasn't sudden onset, no, the patient was asymptomatic and functional cyst would have been on the ovary itself before. So hydrosalpinx or fallopian tube tumor often is a result from something that causes scarring of the fallopian tube itself. So maybe a previous ectopic pregnancy, or maybe a previous ovarian or fallopian tube surgery, maybe PID, chlamydia. Remember, chlamydia oftentimes in women can take months and months and months before it's diagnosed. And damage gets done every day that the person has chlamydia and is not been treated. So you have hydrosalpinx from we get that from the old sexually transmitted infection, or a recent one. Even if they had a few months ago, you can still get that scar tissue, or again, pelvic adhesions. Endometriosis can cause this as well, right? Because of the scarring that the endometriosis causes. These patients often don't have any symptoms. If they do, it's more of that nondescript, kind of achy abdominal pain, oftentimes worse just before the menstrual cycle. Does that make sense? It does. And the reason why it makes sense is because we talked previously about endometriosis and the theory underlying endometriosis. And one of those theories, the main theory, was retrograde menstruation. Well, almost every woman has retrograde menstruation. So they're bleeding some out, but also some of that blood is coming back up and out the fallopian tube. Well, if you've got a fallopian tube that's blocked, that's going to cause increasing pain on that side during that time period. Diagnosis is usually transvaginal ultrasound. Sometimes a diagnostic laparoscopy is done, but usually not specifically for this. Oftentimes for infertility, they'll do a diagnostic lab, or they think the person has endometriosis that's causing their pain, and they'll do a diagnostic lab and identify it on diagnostic lab. Okay, and then the treatment is gonna be either self-ingectomy, okay, or a self-negostomy. And ectomy is they're removing the fallopian tube. So self-negostomy is they're actually taking and cutting a hole in the fallopian tube. If there's a tumor there or there's scarring, cleaning that area up and then sewing it back up. Of course, by doing that, we increase the risk of them developing this again later on. So you always want to ask the patient if they have a history of any sort of, GYN surgeries, fallopian tube surgeries, that would increase the risk. Now, for hair, any hair? Okay, if your patient had a recent history of chlamydia, so last week or so, and now has fever, lower abdominal pain, there's copious vaginal discharge on exam with cervical motion tenderness, unilateral adnexal pain. How does that change your differential? What do you now add into your differential? PIDs, okay? And with PID, of the Cheetah's pneumonic, what do you think that could cause? T? Think like maybe like an abscess? Potentially. Gee, so probably, again, if they have a fever, we have PID, which is really sounds like what this patient has, but now they have adnexal pain and a fever, that's important to know. Because you can treat PID as an outpatient. You can actually treat PID as an outpatient as long as they're otherwise stable, but you cannot treat tubo-ovarian abscess as an outpatient. So if they have any adnexal pain on exam, if they're febrile, you need to get that ultrasound to make sure they don't have an abscess before you can put that in a differential. Likely PID based on these things, unlikely tubo-ovarian abscess because they have no adnexal pain. What? They did ultrasound. Oh, I need to get my ultrasound, right? So you can't rule it out unless we have that imaging. Because even on exam, if you don't feel anything, we still need to get that ultrasound. Just because you don't feel it doesn't mean ultrasound won't see it. So tubo-ovarian abscess is going to be infection or inflammation of that fallopian tube, usually as a result of an STI, PID, endometriosis, or even appendicitis or diverticulitis can also cause a tubo-ovarian abscess by virtue of the way where it's located next to the fallopian tube. So if you had, especially if you had an appendicitis or appendix that ruptured, now they have the abscess material anywhere that could cause tubo-ovarian abscess as well. So lower abdominal pain in the setting of fever and adnexal mass, that is a tubo-ovarian abscess until you make sure it's out with the ultrasound. If you get that ultrasound, and the ultrasound doesn't really give you a clear idea if this is a tubo-ovarian abscess, these patients may in fact need a CT of the pelvis. Okay, yeah, not normally a pelvic MRI, you're not doing a laparoscopy, but we may need to change that imaging. If ultrasound is completely normal, we got to make sure that we don't have anything else besides this PID. We may have to add additional imaging in here. If these rupture, these patients tend to get pretty sick pretty quickly. For about 24 hours, they're septic. And so that's why they have to come into the hospital for monitoring and for IV antibiotics. If they put them on IV antibiotics, they usually give them about 48 hours. If they're not getting better, they'll take them to surgery and they'll drain that abscess. So here we have a picture of the uterus in the middle, and then we have our ovaries are kind of white, and then you've got an abscess. You can see that enlargement of the fallopian tube. It looks like a sausage straight, so on the side. Okay, case 5 for Moyer.
Over the right.
Moyer. Okay, 35-year-old comes in. She underwent fertility treatment, and is now 8 weeks pregnant. She comes in because she has, diffuse abdominal pain. She has this pelvic pressure. ACG levels are 250,000. That's really, really high for 8 weeks. Really high. That's really high for 9 months. So that is way too high, so you wanna think about that. Transvaginal ultrasound, multiple cysts on the ovaries, and bilateral ovarian enlargement. We recently talked about something very similar. So of your Cheetahs pneumonic, what do you think your top 3 differentials for this patient?
The
Fecal lutein cells, yep.
simple cyst,
Simple cysts, teratoma, and really, we probably still need an ectopic in there, right? Because we didn't say, we said she's pregnant, but we didn't say where that pregnancy was located. So probably still in there, but that's okay. We can identify that with our ultrasound. Okay, so of this list, what do you think's going on? Fecal lutein cyst. Okay, fecal lutein cyst. Technically, does she have polycystic ovaries? Yes, but it's not polycystic ovary syndrome, and that's different. She has multiple cysts on her ovaries, but not from a syndrome. It's specifically from these high levels of HCG. So fecal lutein cyst. Fecal lutein cyst, if you remember, we have fecal and we have granulosa cells, and those are part of the ovarian cells, right? Well, here, what we have is like this overgrowth of these fecal lutein cells, and it's from high levels of HCG. Those high levels of HCG are often due to fertility treatments, but there's other things that can cause this as well, something like gestational trophoblastic disease, and we will talk about that specifically in our pregnancy lessons. But gestational trophoblastic disease has excessive growth of the trophoblasts, and the trophoblasts kick out this HCG, and so HCG levels can be in the 300,000 or 400,000 with these. And then if you have a multi-gestational pregnancy, we also have an increase in HCG, and so that can cause some fecal lutein cells and stuff as well. Here we have enlargement of those ovaries, and sometimes the ovaries greater than 30 centimeters. Remember we talked about hyperovarian stimulation syndrome, which is that the ovaries are meeting in the middle, and that's kind of what this causes, and these patients have those same signs and symptoms, abdominal pain, discomfort, bloating, and multiple cysts. So many patients initially with a small cyst, they can be asymptomatic, but the larger those cysts get, the larger the ovaries get, the more symptomatic they're going to be. And they're going to have abdominal pain, bloating, pelvic pressure, significantly elevated HCG levels, and then they're typically the uterus is much larger than we would expect. So they're 8 weeks pregnant, but we go to do an exam that seems like they're 12 to 14 weeks pregnant. Like their uterus is well above where the pubic symphysis is at, so much larger than we would expect for that stage of pregnancy. And that's due to those elevated HCG levels. We have diagnosis on ultrasound, and then if this is due to fertility treatment medication, we just discontinue the fertility treatment medication. And again, most of the time, you guys are going to be in a position that you're prescribing those medications, but if you're seeing a patient that's on those medications, you can't get a hold of their fertility doctor, then your recommendation to them would be they're otherwise stable. I recommend you stop these medications until you get a hold of your doctor, because this is what's causing your signs and symptoms. And they usually have a good follow-up with them, so it's not that big of a deal. Otherwise, if there's a tumor that's producing the HCG, or if it's something like gestational trophoblastic disease, then they need to have surgery, something like a DNC, to be able to get all that material out of the uterus, or remove the tumor that's producing the HCG. All right, case 6, Lynn. Okay, sir, so you got a 28-year-old female coming in. She has got sudden onset of right lower quadrant pain, started after having intercourse. She has a known history of ovarian cysts, and she's not using any contraceptive method. Oh, dang. Right lower quadrant tenderness on exam, pregnancy test is negative, transvaginal ultrasound shows free fluid. What are your top 3 differentials on here?
hemorrhagic ovarian cyst,
Okay,
endometriosis,
and what was the last one? Simple cyst? Okay, all right, I think those are pretty good. Would you say endometrioma? Could be. Okay, all right. What about this list? What do you think we would narrow it down to? Probably, maybe a ruptured ovarian. History of cysts, sudden onset of pain, okay? Dermoid cyst means more that constant pain, unless you have associated ovarian torsion, and so that probably needs to be up there on your differential, right, for this patient. Ovarian torsion for sure, especially with that history of ovarian cyst. Okay? Not likely cancer, given the presentation. Alright. So ruptured ovarian cyst, we're going to see this most commonly in reproductive, but we've also can see it in the postmenopausal time period as well. And here you can have release of, from that cyst rupture, you might only have cystic fluid in it, or it might have blood in there. So you can release either that fluid or blood. And oftentimes, when this ruptures, it often occurs around the time of ovulation, so mid-cycle or so. And we already talked about, especially in the setting of a person that has functional cysts, or corpus luteum cysts, or follicular cysts, we want to talk about those patients if they're not planning on getting pregnant anytime soon, about putting them on a birth control to help stop them from ovulating, to reduce their chance of potentially having a ruptured cyst. Because the problem is, we don't really know why these ruptures occur. So it's hard to prevent something you don't know why it occurs unless we give the patient a medication to prevent ovulating in general. We have increased risk for rupture. We know with like extensive running or aggressive intercourse or even a recent fall, like a fall, anything that jars the lower abdomen, that increases risk of rupture. And then we talked about the right ovary that is more common not only with ovarian torsion but also with rupture as well. If they have rupture of that cyst, they may at the very beginning be asymptomatic or like, man, that's a little uncomfortable. But then within an hour or so, these patients are usually fairly uncomfortable, and usually that's what's going to prompt them to come see you, is because of the discomfort that is continuing to develop. Okay? And for these patients, if you're seeing them in the clinic, this might be something that you're seeing them pretty quickly, low abdominal pain, and you're probably going to have to send them to the ER to help control their pain and for the appropriate imaging. But here we have a picture of a hemorrhagic cyst that ruptured, and then we can see this is a laparoscopy with the amount of blood that this patient was losing. So I've seen this on a few occasions. When you check their labs, initial labs may be normal. It's those repeat labs that you want to make sure that you get. So vital signs, oftentimes normal initially, but if they have continued loss of fluid, they're going to become tachycardic and they're going to become hypotensive. That is indication of hemodynamic instability. And young healthy patients typically have a blood pressure of 90 over 60 and a heart rate of 50. It's going to take quite a bit of time for them to get to a heart rate of 120 and a blood pressure. Well, they're already hypotensive anyway. So, but if they, you'll notice that in active duty people, it takes quite a bit longer, a lot more blood loss before those patients become symptomatic. On exam, they usually have lower abdominal, unilateral abdominal pain. They might have peritoneal signs, especially in the setting of blood that's being released. And then you want to make sure that you do your pelvic exam and your bimanual exam. For these patients, they may actually have cervical motion tenderness, but they're not going to have any like STI history, no discharge coming from the cervical os, nothing to indicate that this is an infectious etiology. Labs, we've got to get that HCG, okay, because can someone be pregnant and have a ruptured ovarian cyst? Yes, they can certainly have that. CBC, not just now, but repeating that CBC, okay? You're going to repeat that H&H. So what I typically do is when they come in, I do their evaluation, I do an initial set of labs, and then before I plan on discharging them, I'm repeating that H&H. And if it is stable, sometimes it's dropped a little bit, but it's otherwise fairly stable, then I'm okay with letting go. Once the H&H, you have to be really cautious in the setting of someone that's having a bleeding, because you don't know if it's actively bleeding. And from the very beginning, I'm going to order a type-in. Am I going to order a type-in screen or a type-in cross?
Screen.
Type-in screen. Type-in cross means they're already hemodynamic unstable, and I've got to give them blood because they're holding this blood for them. So type-in screen is I'm preparing in the event that they need blood. And then if they have a fever, there's nothing wrong with doing STI screening. CA-125, not beneficial, or most likely will be elevated in this patient. Transvaginal ultrasound is still going to be our study of choice, okay? And that, again, helps us identify what do we have going on. Do we have leakage of fluid? Because radiologists will see that that cystic wall is ruptured, and they will also be able to tell you if this appears to be hemorrhagic ruptured cyst or a non-hemorrhagic ruptured cyst. CT, MRI, again, not beneficial in these patients. Matter of fact, where do patients go to die? CT and MRI. So especially these patients, if they a little bit hemodynamically unstable, you don't want to have them going out of the clinic without monitoring, or if you're working in an urgent care area or the emergency department during rotation without monitoring. We want to control their pain, and we want to observe these patients in the clinic or your ER or acute care clinic, wherever you're working. You got to observe them for a couple hours. There's nothing wrong with giving a little bit of IV fluids. You don't need to give them 3 or 4 liters of IV fluid because all you're doing is hemodiluting. Right, but give them a little bit of fluids, monitor them, make sure that you're prepared to give them blood products as needed. So this isn't a person you want to sit on in the clinic until they're hypotensive tachycardic. This is a person that you pretty quickly are going to identify that they need to go somewhere else and get the ambulance and have them sent. They shouldn't be driving themselves and usually not someone driving them either, because we want to get them to the next level of care as soon as possible in case they need emergent intervention. Okay. If these patients continue to bleed, they may have to go in and do surgery on them, or if there's any evidence of infection, sometimes they have to do surgery in certain elements of malignancy. So the patient comes in, the biggest thing we want to identify, are they hemodynamically stable or unstable? If they are hemodynamically unstable, we got to give them blood products, we got to resuscitate them. If they are stable, and we don't have concern for infection or malignancy, or monitor them for a couple of hours, or doing okay, we can send them out of the hospital. They don't really need any additional treatment except for anti-inflammatories. This is not the time, even though these patients are very uncomfortable, it's not the time to give them narcotics, because we want them to come back if they get worse. You give them narcotics, and they're like, well, my pain got worse, I'm going to take this narcotic, I feel way better. But then we're going to miss something, or the patient's going to cover up something because of the narcotics. So stick with the anti-inflammatories or acetaminophen. Certainly if they're hemodynamically unstable, then they've got to be hospitalized for intervention. All right, almost done here. This is our last case. Morris. Okay, ready? 42-year-old female comes in. She's got dyspareunia. She has chronic pelvic pain. It's been going on for the last 3 to 4 years. On exam, she has lower abdominal tenderness. Speculum exam was painful, but otherwise unremarkable. ACG, urine, and STI panel that was recently done was negative. Of these, what are your top 3 differentials?
Endometrioma, abscess,
Cystadenoma, okay. And even simple cyst, I guess, but it's been going on 3 or 4 years, so that would be unusual, right? Okay, what do you think of this list? What do you think? Endometrioma. She's got some of the D's, right? It's been going on for quite some time. Our basic labs are negative to include HCG. There certainly are concerned that she may have an endometrioma. Now, she may not have a diagnosis of endometriosis, but if we get an ultrasound and it shows an endometrioma, that's her diagnosis. She has endometriosis. Okay? So now we can manage these symptoms that she's been having for 3 to 4 years. Okay? So if they have endometrioma, that indicates more of a severe form of endometriosis, which again would be accountable for this patient's symptoms that have been going on for 3 to 4 years. And what we're seeing on this imaging is just an endometrioma. We know that is a fluid-filled sac, but what we have in there is those degenerated blood products, those old blood products. We call them also chocolate cysts, is typically what they're referred to in the literature as well. So these patients don't necessarily have signs and symptoms associated with endometrioma. They have signs and symptoms associated with their endometriosis, so the ED, the dyspareunia, dysphagia, their infertility, and chronic pelvic pain. We still use a transvaginal ultrasound to help us identify this because of the amount, because of the complaint of pelvic pain or adnexal pain. And then treatment's gonna really vary. If it's less than 4 centimeters, we can kind of monitor this until it gets a little bit larger. And then they oftentimes, if it gets greater than 5 centimeters, most of the time they'll go in and remove it. These patients oftentimes get repeated surgeries for reaccumulation of the endometrioma. So I know patients have had 8 or 9 surgeries for endometriomas. And if they're postmenopausal, it's unusual to have endometriosis when you're postmenopausal. It's unusual to have endometriomas, so those patients need to see GYN. Now, if you get imaging, so a patient comes in, they've got lower abdominal pain or pelvic pain, adnexal pain, you get imaging, and that imaging has multiple septations. That's bad. That's bad. This isn't a follow-up in 6 to 12 weeks. This is, I don't know what's called, I'm sending you to GYN. That's usually bad. If it says concern for malignancy or neovascularization, neovascularization means you have new blood vessels that are going somewhere. And it's probably supporting a tumor that is growing. They need to be referred to GYN. There's nothing wrong with grabbing a CA-125 in these patients. Like I said, I only typically do that if the consultant asks me to do that, and that gives us a baseline. But these patients need to be referred. You may have a question to ask about multiple septations. It's not follow-up with you. It is a GYN referral. All right, that is it for today. Thank you.
Thank you.